I would like to thank, really from my deep heart, my family, Salama family, and Dental XP family. And for sure, Team Atlanta and all those guys who made us excited on science around dentistry. I'm coming from Morocco, a simple country, north of Africa. Beautiful country, many different areas, snow, sun, sand. And I just want to tell you about an event, which is a COP22. It will be held in Marrakesh in a few weeks. We moved to ecology a few years ago. And that's why I think they decided to do this COP22 in Morocco. We have one of the biggest sun field in the world, and we are moving to, that's like ecologic buses, electric buses, and for sure, organic transplantation. And I think the Salamas tried that when they were in Morocco. I will start with a movie, a surgical movie with a new kind of surgical guide. I will try to give you just a few small informations during the movie, and we will see all that in details. This is a kind of charting we gave to the dentist to see exactly what kind of drills he can use. So for sure, when it's a full arch, we will stabilize this 3D metallic printed guide with the three screws. And then we start the drilling. And I know that Howie will be upset, but we could do the flapless surgery because the soft tissue is just amazing. So be aware of this. It is a kind of stops we use to under drill when we have a smooth and type 4 bone. We down the drill using stops. It means that the dentist will not need to think if he wants to down drill or not. Everything is set from the beginning. So this is a situation at the end. All those abutments or provisional abutments were set in a model, and the provisional, as you see, is quite nicely adapted. We have to realign it a little bit because of different problems related to CBCT. Still have problems with CBCTs and with all the other components used for guided surgery. It means that this kind of surgery took me today in my office 45 minutes, including provisional. It's just amazing for an experimented implantologist. We know how to put implants, but we really need to have the provisional ready before the surgery. So this is the radiographs after, and you see that we really avoid the sinus. It's a patient with a lot of heart problems, a lot of medicine, and he never decided to do implants because of bleeding and all those problems he can have. So this is what we call the dry surgery. We will use this particular guide to prepare the provisional. And this plaster model used every osteotomy site is accurately planned, and every implant analog carefully placed also with the guide and stabilized by hard dual cured resin. So before doing the surgery, we have everything. So this is the simulation and the result, and this is the final prosthesis. So let's be back to the basis. Replacing missing teeth and implant-supported restoration represent both surgical and restorative challenge, with or without the help of computerized guided surgery. Most of those challenges are, or often, can be lack of space, issue with root conversions, bone defects, concavities, soft tissue concerns, emergence profile, and also sufficient bone density to stabilize an implant for immediate loading. And this is quite easy to know with the ISQ value, but it is done during the surgery. We can know exactly if there is a risk under 55, or we have to watch out for the provisional and the occlusion, or we can go for a final prosthesis. Be back to what Dr. Park showed us yesterday. It was very interesting, and this is a software I'm using now since 3 or 4 months. It's free of charge. You can download your radiographic documents, and you can have an idea about how soft or hard is your bone. The second challenge is the operator skill. For sure, if you're not skillful in normal implantology, you can have problems with guided implantology too. So, as an implantologist or as an endodontist, it's exactly the same. We're not skillful, and that's it. So the most important thing is the depth. The medial distal position and the buccal lingual angulation can be easily, with some training, we can reach the excellence. But for the vertical depth, this paper is very interesting. The conclusion is that the most important inaccuracy with guided surgery is in vertical direction. The inaccuracy of mesiodistal and buccal lingual direction is clearly less. So, another interesting paper says that when a computer-guided protocol was used, the accuracy of the vertical dimension was most influenced by the operator's level of experience. So if you follow me well, we need guided surgery to help us, or we need to be excellent and then use guided surgery to give lectures. What is the aim of guided surgery? It's to give me the possibility as a young inexperimented dentist to identify and to do implantology without any kind of risk. And for the experts, and I see 10th in this auditorium, to save time by having already the provisional ready to place immediately after an open flap or flapless implant surgery. This is the standard way we use since many years with some problems. Now we want to promote guided surgery, so we will point on the problems with the normal implant surgery, swelling, everything, pain, and for sure patient time and money consuming. So let's be back to the history. I'm grateful to my friend Alvaro Ordonez for giving me those documents. You all remember the use of barium sulfate to have the possibility to do the first drilling and to be in the right axis. But the revolution is really the correlation and transfer between, it can be done between dual and intra-extraocular scanning. And this was done, the beginning, 2008, I think, by these glass beads. We can transfer the position of the prosthesis to the radiographic documents by means of this very easy tool. But now we are using, in this proper case I will develop with you, we are using a Lego brick, which is quite amazing because it's totally radio-opaque and it's tridimensionally possible for us to see if the scan is good or not before doing any kind of work to realize the guide. And for sure, the merging, what we call the merging. And I agree with Dr. Park. The way to merge the radiographic and prosthetic documents is, for me, the most reliable until now. So why a Lego brick? A Lego brick, we have a kind of a Lego brick in our computer, and we can just have to put it on the one in the radiographs. And you will see that if there is a problem with the scan, which is one of the most biggest problem to succeed in guided surgery, we can see that there is a problem, and we will do a new scan before doing any kind of plan. Those papers were published by Marcus Abboud, very valuable papers, comparing the use of this Lego brick with other materials to merge the radiographic and prosthetic documents. So easily, we have to put either in the impression or in the wax-up, the Lego brick, and then we will scan in a flat scan with 3 references. And you have the edentulous jaw, you have the prosthesis, the future prosthesis, and all that will be merged with the bone to have the possibility to do a kind of simulation of the surgery on the computer. So let me share with you this. I'm really worried when I see that. It's a paper from Jaime Lozada for the Academy of Osseointegration. Guided surgery, heaven or hell? He explained that, and he said that guided do not replace insufficient level of training. It's like when a blind guy asks you to help him to cross the street. You just have to say to him, please give me your hand, and don't worry, you will be at the other side in 5 seconds. Or you give him a kind of assistance, and you said, please, you have to watch out. There are probably very quick cars and holes in the street, and you have to watch out. The blind man will say, please just let me alone. I will do it myself. It's exactly what we have today with guided surgery. Sometimes it's more difficult to do a case with guided surgery than without. And so this is, in my opinion, related to very big mistakes done from the beginning. From the beginning, we try to guide our implant from a central hole. And then many researchers all over the world, they're working on this problem. How to irrigate, how to stabilize, how to see the surgical field, how to fill or to cover up with the guide in place. So we started from the beginning with the wrong problem, and we try to have the solutions. I'm really not saying that it's not a good thing. It's the basic of guided surgery. And now there is an evolution. And we have a monster here, which is my friend Scott Gans. I read your book. You remember when I called you and I read your book in 5 hours. Really read it. Because those references are very important for us. But it means, and I was happy to see the lecture of Marcus, who said that in 2050, all what we are doing here, we will laugh. If we're still alive, we will really laugh of that. So we have to be open-minded, because there is many other things. This paper is quite interesting too. Inexperience of surgeon had no influence on the accuracy of implant placement in fully edentulous jaw, when all steps needed for the procedure are supervised by experienced dentists. What does it mean? You need 2 guides. A guy done in the laboratory and a guy behind you. You say, go in left, go on right. So if you knew that, we need 2 guides. Thank you. Now you know that we need 2 guides. So this is the procedure, and Michael Picos gave us all the information about the procedure, and we will not continue on that because I don't have much time, and I want to go to another more important things. So this is the procedure with this metallic printed guide. Scan, impression with the Lego brick, a setup, and then the study and planification and the milling. So what do I need if really I want to use guided surgery? I need a patient with an dentist area, and I need a cone beam and a model, either printed or plaster model. And to be sure that this patient is not a candidate for guided surgery, but for implantology. But most of them now, they came to your office and they said, I want guided implantology. So but your case can be done without guided implantology. It means that it's a very important detail. So this new, I think, I'm not comparing brands. I'm comparing two philosophies in guided surgery. External guiding and internal guiding by the tube. And this guy is a lab technician. He's the inventor of that. I will compare with you this and this. Once more, it's not related to brands. It's related to philosophy. Contamination. This can be sterilized. This, we have a kind of resin we can sterilize, but we still have some distortions. Feasibility. Here you can do whatever you want. You can fill, cover up, do whatever you want with the guide in place. Here you're like a blind guy doing surgery, and sometimes it's terrible. Accessibility. You have access to the surgical field. Can you imagine this? I took it from a book. The guy is doing Summers technique through the trim, through the guide. Can you imagine that inside the guide there's no saliva, no bacteria, and he's pushing everything inside the sinus. And it's published. Quite difficult to imagine. So this is a case, a surgery, showing a premolar and how, by using this kind of guide, we will do the provisional, stabilize the analog. I did a mix between a 3D movie and real, but it's exactly the same case. So we'll be very careful to move to extract the roots. Here we used the osseocondensator drills because it is possible, because everything is stable. You cannot use a reverse drill if you're not totally stabilized by the two pins. So when the implant is inside, here we place the implant with a PRF or a membrane to reinforce the buccal part, and then we fill up with bone, any kind, to your choice. And then we stabilize the implant because the drilling was very secure and exactly at the axis of what we decided on the plaster model. So this is, the other thing is the irrigation. We cannot irrigate. And now I have a student in Naples who's doing his thesis on how to irrigate under a surgical guide. He spent hours doing a work on that. It's amazing, really amazing. And then, last but not the least, the instrumentation. I love what you said yesterday. Have to do a PhD to here you have really to do it sometimes in some of the tools. You really have to do a PhD to know how to put the spoons, the first one, the second one, the third one. It's just amazing. So what is the other the big problem in guided surgery? It's the consideration of patient mouth opening limitation. When you try to do guided surgery in the posterior area, you need 51 millimeters if you want to use the normal guide, which is the guide with the sleeves, like the Nobel guide or other ones. Here we spend a lot of time to find a system who will reduce this from 51 to 29. 29 is quite interesting. And 4 engineers work around a year to find a solution to put this guiding, external guiding, used in all the situations in the posterior area. So this is an example with the standard drills of Nobel Biocare. You can go here from 26 millimeters for the first drill, the 22 millimeters pilot drill, and the maximum with 13 millimeters. If you want to put a 13 millimeters in the posterior area, you're reaching 38 millimeters maximum. It means even with that, the worst situation, 13 millimeters, you gain a lot of things. And this is very genius because you have 2 stops. You know, it's like les attachements en protège, c'est quoi ça? Attachments. It's exactly the same. But you have 2 different levels, and it's directly printed on the guide. It means that you have different levels, and you have to use just your contour angle or your and one head. You don't need anything else. So this is a case, a very scary case. This is the beginning of the case. This is the simulation, the guide with the provisional, and the case finished in the laboratory. This is the situation, exactly the same, and this is the situation, which is exactly the same, thanks to a kind of software, quite serious software, and a guide which is quite interesting. So this is the surgery of this case. We used a new 4 by 4 millimeters, an ultra short implant. And you see that during the surgery, I have to stabilize it in 4 point because it's very important. And then you have a cross in the middle. You have to put your finger on it to stabilize it. And you will see that I can do some drillings. I can do some drillings with the guide in place. But in some others, because this is the old, the generation 1 of this metallic guide. And this is the stop. When you give the charting to the dentist, don't tell him, watch out. In the final drilling, you have to be 1 millimeter above. No. Please take the guide and do what you have to do. You have a charting. So this is the implant. And you see that I put the implant in the holes, and then they put everything inside the mouth. Why? Because at that time, we had the first generation of the guide. Now we save around 22 millimeters comparing to this one. So those prosthetic abutments were set on the model, and then very easily you see the adaptation. Very easily you will see exactly the same thing in the mouth, including an occlusal setting in the depth region. So you can understand that we put the limits above the gingiva to avoid any kind of problems related to cementation. So this is the new guide. It's the first time I can show it because it was quite difficult to have it, and you know how it works with the patented things. It's just a nightmare. So now it's the first time ever we see this guide. And you have 2 levels of stops. And the head of the contra angle can go inside. It means that you will save all the height of the drills. So this 3D movie show you exactly the same case than the live surgery you showed, and those were reduced in the lab, and provisional is done. Here you can see how crazy I am. It's my aunt, the only aunt I have. And since I began, since I became the specialist in the family, she was asking for implants every day. I want implants. You're the big specialist. And when I find this and I try to do it, you see this one, I'm really on the top of the nerve. Last but not the least, you all know that part of my job is to give lectures to engineers in implant manufacturers. So implant surfaces was part of my PhD thesis in Sweden. How can I imagine that this implant surface will be scratched all along the sleeve, even if it's a titanium sleeve? They said, no, it's not a problem, it's a titanium sleeve. So keep your new implant and just brush it with a titanium brush and put it inside, and you will see if the results is the same. So this, I don't want to show that because there is no kind of comparison between what we are playing with, the central hole, and this external twin guide surgery. So the workflow, just take an impression with a Lego brick. It doesn't cost anything. Lego brick, you can find it down of your kids' beds. And it don't cost anything. And then you just have to glue it on a standard impression tray. And then you take a CT scan or CBCT with that, and the model is poured with the Lego, and a first scanner is done with these 3 ones. It means that you have the edentulous part with these 3 ones, and then the wax up with these 3 things. And since you have the bone with the first Lego, you can match everything very easily. And then, when you do the planification and you have your prosthesis setting, this is printed, 3D printed with laser sintering machines, because it's impossible to do it with drilling, for example, or a wax technique. So you can use, what is interesting too is that if, Dr. Garber, you're using an implant brand since 20 years, you can continue to use it. I will not say if you want to do guided surgery, you have to move to another one, because we have the set, we have the adapted set for that, and we have everything. So this is, you will see that in other things. So what is the major important thing? Is dry surgery. We put that and we see if it's totally adapted to the impression. It means if it's adapted here, it will be adapted during the surgery. And then we start to drill. And the evolution, and I'm always thinking of my friend Marcus Abud, the model will be printed with your analogs in the right place. It means that you will have the analogs printed inside the model, and your lab technician will work on it like on your impression. So this is how it looks with the abutment in place, and then he will do his provisional very easily. And he put the limits above the gingiva or do the screwed prosthesis. This is the case. And this is the 4 implant placed. So what is interesting is when you do this dry surgery with this guide, you can deliver to the dentist either a provisional, because he wants to do it himself. Some dentists, they want to do their provisionals themselves, to finish the provisional themselves, or to do it with CAD/CAM, as Marcus showed us in his lecture. So this will be, when it will be printed, it will be like this. It will be done directly on the model. So this is a case. I have 2 cases left. Can I know how much time I have? Okay. So this is a case with 2 premolars. So you see the 3 LIGOs and the central LIGO. And what is interesting is that we receive this kind of charting. You have to use this burr, this one, you have to avoid this one, and then you have to down drill for the root tooth number 15 because the bone is very soft. And to under drill, you have to use this spacer of 1 millimeter or 2 or 3. Everything is said before. It means we are guiding the surgeon from the beginning to the end of his surgery. And those are the stops. This is a 1 millimeter stop. You see that I'm using zirconia drills, but you can use your own drills of your system, your own system. What is interesting is that you will use drills with a flat head because there's no possibility to twist. It means that you're cutting, especially when you have a very small bone crest, will be very precise. So let's go further. You see that? We stop exactly in the wall of the sinus. We did, for the science, we did an impression with the pickup technique, and we did an impression with the intraoral camera to compare. And we see that we move with the crowns from this model, the virtual one, to the model with the standard impression, to the one with the intraoral camera. A last case, and people who are doing implantology in many years, they will understand how it's difficult. See how deep is the soft tissue. And here it's really non-invasive surgery. Because with this kind of crest, you will see the scans, it's quite impossible to drill with the proper angle. It's too deep. Then we put this implant. We set a provisional with a cup done before. And for this case too, and for the science, we use a standard impression. You see how deep? It's a 5.5 abutment. And this is the result with a very healthy soft tissue. We do not remove the papillas. So the near future is what? This is a case where Marcus Abboud talked about that, but it's really, we have some cases running. We can copy the roots and print the implant, but the problem is still the connection between the intraosseous part and the soft tissue part of the implant. And this kind of guide, for sure, it's different than the ones we know. And for sure, we have to develop it. We don't say that it's the best one. Myself, today, I have 6 problems with this one. And 6 problems you, as a dentist, you will never see. You will never see. You will probably discover those problems in 6 months. But who cares? We don't ask you to buy anything, a set or nothing. You have a head to put on your counter angle, and the stops. It costs nothing. The LIGO costs nothing. That's why it's disturbing. There's no business behind. Or a small business, which is the cost of the guide itself. You don't sell anything else. Thank you very much for your attention.